thought was truly diphtheria. The kid came in, sore throat, and he had this gray-looking appearing back over his tonsils. And you'll see that here in a little bit. Okay, same generic lecture. Okay, what is tetanus? So tetanus is an infectious disease caused by contamination of the wounds from a bacteria called Clostridium tetani, or the spores they produce that live in the soil and animal feces. So tetanus is characterized by an acute onset of hypertonia, painful muscular contractions, usually of the jaw and the neck, and generalized muscle spasms without other apparent medical causes. And that's just a little picture of what Clostridium tetani looked like on microscopy. So tetanus is an international health problem as spores are ubiquitous. So they kind of can grow anywhere and everywhere. The disease occurs most exclusively in persons who are unvaccinated or inadequately immunized. And that's a big issue now with immunization, and you guys will probably hear a lot more about it in pediatrics, is a lot of the parents these days are concerned about immunizations for their children because they worry about their children developing autism. I will say my brother was one of those people. I was like, he did not give their kids vaccinations, but he would delay it, you know, like, because I want to say it's your 4-year-old, you get 4 shots, you know, and so some of those visits, they would get multiple vaccinations, and he was concerned because my nephew, you know, it was a boy, and so he delayed it. He eventually got all of the vaccinations, but I had a friend who actually did not immunize her child, which I thought was very interesting because he was born a micro-preemie, so he was born at a pound. You would think someone who would need it would be him, but she, again, was worried about his immune system and then him developing autism, which he would have had a higher likelihood anyway due to his low birth weight. But she actually went to a pediatrician who, well, my friend says that she left the practice, but I think she pretty much got fired from her practice because there are a lot of pediatricians that will fire parents that don't immunize their children because you're bringing that child into a clinic full of other immunized children, that the possibility is still there if your child has something that they can pass it on to those kids. So that's something that you guys might see out in practice eventually. So tetanus occurs worldwide, but it's more common in hot, damp climate with soil that is rich in organic matter. It's more common in developing and underdeveloping countries, more prevalent in industrial establishment where agriculture workers are employed. See, now I understand why they have those red little lines around the PowerPoint, so you don't go beyond it and it doesn't look like this. So causes, tetanus spores are found throughout the environment, usually the soil, dust, and animal waste. It's usually acquired through contact with the environment, but is not transmitted person to person. Sorry, that's just a thought. And how does it get into the system? It's usually through puncture wounds. Those are caused by rusty nails, splinters, human bites, or insect bites. Also through burns, any break in the skin basically. And it's common in IV drug users, obviously, because they have open access for bacteria to invade. That's why anytime you'll see when you're out working in primary care, your patient comes in and they cut themselves on a saw or they got a nail in their hand, you always need to ask, is their tetanus up to date? And when was their last tetanus? And usually your tetanus shot lasts for 10 years? 10. But a lot of times if they're not insured, I send them to have a booster anyway. So this is how, basically goes a little chart, how tetani enter the skin. So enters body through a wound, and then it stays in a sporulated form until the conditions are just right. And they will begin to multiply and produce the neurotoxin, or tetanus spasmin. And then that spreads through the body, through the blood and lymph system, and binds to motor neurons. and then it travels along the axons to the spinal cord. And then binds the sites responsible for inhibiting skeletal muscle contraction. So, how long does it take for someone to get sick? So, time of exposure is usually, 3 to 3 weeks. On average, it's 5 to 10 days. And sometimes it can range from 1 day to several months, depending upon how big the wound is, and how infected it is in the area. Most cases occur within 14 days in general. So there's shorter incubation periods, again, like I said, with heavily contaminated wounds, more sort of severe disease, they have a worse prognosis. So what is the type of wound that you worry about? So a wound sustained more than 6 hours before they have had surgical treatment, and wounds sustained at any interval after injury, which is puncture wound type, or that shows a bunch of open wounds, open sores, or is septic or is contaminated with soil or manure. So those workers that work in, mulching or gardeners, things like that, that might have a higher risk, or work on a farm that handles a lot of manure or soil, they would be at higher risk. And obviously any puncture wounds. So signs and symptoms. Tetanus is often called lockjaw. You guys probably heard that, growing up, that someone gets a lockjaw. But that actually happens later on. They just get more of a jaw stiffness initially. And then they get headaches, sudden involuntary muscle tightening. They can get muscle spasms. They'll get some jerky movements, and sometimes they can develop seizures. A lot of them will have dysphagia because they also have esophageal spasms, so they're not able to swallow, so they'll be drooling. And then sometimes they just have painful muscle stiffness throughout their whole body, and they sweat. They sweat a lot. And so in some people, you have a characteristic facial muscle spasm. They have a fixed smile with elevated eyebrows, and it's called rhisis sardonicus. It could also be someone who has a lot of them. You have tonic contractions called opisthotonus. It's kind of a hard word. So they have flexion and adduction of the arms. They have clenching of the fists, and extension of the lower extremities. I think I have a picture right there. Oh. That was the face, sorry. And this is that when they have their arch, their back is arching. See how is that smile? And that's a baby, a neonatal arching. Okay. They can have characteristic painful generalized tonic spasms like I talked about, profuse sweating, and it could just be a minor disturbance like a draft noise or movement can have this onset. But their mental status is usually normal, but they can fall into a coma due to repeated spasms. They get chest wall rigidity, so a lot of them can have airway compromise, and glottal spasms. We talked about how they will drool and have dysphagia. And so these people are in a lot of pain, but they can't speak out and they can't cry just due to the spasming. And like I said earlier, they will do the spasms in the chest. They can have respiratory issues causing cyanosis, and then fatal asphyxia. That's another little kid. And this is the, I don't know how I did this, it was just by accident, but that's that clenched fist, the arched back, their toes are curled, and that's just an old picture of someone who has a tetanus attack. And so basically, it would be horrible. I mean, your mind is there, and you want to scream out, but you can't. So, how do you diagnose someone with tetanus? There's currently no blood test that can diagnose tetanus. So basically, again, it's history and clinical suspicion. So anyone has had a recent wound, and they come in complaining of muscle spasms or muscle tightness, and that's what you kind of want to think about. Oh, they might have tetanus. Obviously, differentials would be meningeal encephalitis due to stiff neck, mastoid muscle spasm due to dental abscesses, and then a lot of my patients who have had, head and neck radiation, they have what's called trismus. So their jaw locks down, they're unable to open their mouth widely. That's something you could have as a differential due to radiation. And they have a lot of pain in their neck too, because a lot of time the treatment field is in the face and in the neck. And then it can be a drug reaction to phenothiazine, and then rabies. Professor Hughes talked to you guys about rabies the other day, and then also just hysteria. So prognosis, tetanus has a mortality rate of about 50% worldwide. In untreated adults, 15 to 60%, and then neonates is pretty bad. Even if treated, they have a high mortality rate of 80 to 90%. So mortality is highest at the extremes of age, so the older and young, and drug abusers, just because they have wide open access to their vessels of blood and lymph systems. But like I said, we just said earlier, respiratory failure is the most common cause of death for those who have a tetanus infection. Treatment. So the main treatment for these patients is supportive care. The biggest thing will be airway management. Because of their spasming, you may have to intubate them, but you have to keep their airway open. That's the biggest treatment. You can give them fluids, because most likely they won't be able to swallow, and things like that. If they have a bad, ugly-looking wound, debriding the wound is a big treatment thing to get rid of all the spores that may still be in there. And you can give them a tetanus antitoxin. And benzodiazepines for muscle spasms to help relax their muscles, the contractures. And then you also want to give them an antibiotic such as metronidazole or penicillin for any open wound that may be infected as well. And then you can give them morphine to manage their autonomic dysfunctions. So there's also, they talked about something about giving passive immunization with a human tetanus immunoglobulin. It shortens the course of tetanus and may lessen its severity. And I don't know if you've had a lecture, if we really talked about immunoglobulin therapy. I don't know when we have talked about it, or did y'all have it anywhere in any module that you can think of? And the only times that I really remember dealing with immunoglobulin therapy is a lady that had, I think she might have had sarcoidosis or some type of lung issue, and it compromised, no, it's IgE. She had some immunodeficiency, and she would always go to the allergy clinic, and she would get immunoglobulin therapy to help build up her immune system, to help fight, because she'd, everywhere she'd go, or if she'd go to Arizona, she would always come back with an infection of some sort, sinus or lung related. And so they would try to build up her immune system to help decrease her infections and use of antibiotics. So prevention. Tetanus is completely preventable, obviously by getting a tetanus immunization. Oh, there it is, 10 years. Older teens and adults, like I said, who have sustained injuries, you should give them a booster if they don't know, or a lot of times they're like, I don't know when my last tetanus shot was. So anytime they say that, they buy a booster, because you don't want them to not be protected. Okay. So the second one is diphtheria. So diphtheria is an infection caused by the Corynebacterium diphtheriae bacterium. Usually C. diff multiply on or near the surface of the mucous membranes of the nasopharynx or the skin. Like I said, the only one that I did was a kid that had what he thought was strep throat that maybe didn't go away, or he thought maybe he might have mumps. He was treated and it never got better, and he came into our clinic. So diphtheria is spread from person to person. It's usually through respiratory droplets, like from coughing or sneezing. Or you can drink after somebody, after a cup, or use their spoon or anything like that. This is a big one, is use tissue. So kids like to blow their nose or whatever and leave it laying around. You touch it, you pick it up, you somehow touch your mouth or your nose, and you give it to yourself. Same with the toys, like we talked earlier, contaminated household items like towels or toys, and then touching an infected wound. So who are at risk? Usually children and adults who don't have, again, up-to-date immunizations. People living in crowded or unsanitary conditions, anyone who travels to an area where diphtheria is endemic, and diphtheria rarely occurs in the US and in Europe, obviously just because of immunizations, that's why it doesn't occur as often. But again, I think that cycle will change with people not wanting to immunize their children. So like I said earlier, C. diphtheria adheres to mucosal epithelial cells, where the exotoxin is released by endosomes. It causes a localized inflammatory reaction followed by tissue destruction and necrosis. So when that tissue dies, it has this gray-looking appearance to them, either in the posterior oropharynx or sometimes even just the wound if it's on a skin. It has this gray, dusky look to it. So the local tissue destruction it allows the toxin to be carried lymphatically and hematologically to other parts of the body. So elaboration of the diphtheria toxin may affect distant organs such as the heart, the kidneys, and the nervous system. So see that? That's exactly what this kid looked like. He had this gray looking thing over the back part of his oropharynx, and I thought, it kind of looks like exudate, like somebody who had strep, but it had a weird, it looked like a gummy piece that was just stuck back on the back of his throat. So signs and symptoms. So it usually begins 2 to 5 days after a person becomes infected, and they may include, like I said, a thick gray membrane covering their throat and tonsils. They'll have a sore throat, hoarseness. They'll have swollen glands. This kid had, his neck was swollen. And they call it a bull neck because it just looks like a big, thick neck. And some of these people, if they get a lot of swelling, a lot of lymphadenopathy, they can get difficulty breathing, they can have rapid heart rate, they can have tachycardia, sometimes they'll have nasal discharge, fever and chills, and malaise. So in some people, infection with diphtheria causing bacteria only causes a mild illness. So, and sometimes they have no signs or symptoms at all. And those people are what we call carriers of diphtheria because they can cause infection without being sick themselves. So it's kind of like those who have latent diseases, basically. So here's a picture of a skin or cutaneous diphtheria. So it's a second type of diphtheria that can affect the skin. So usually they have pain, redness, swelling, and they too will have that ulcer with like a gray membrane on it. That's a small little picture there. I don't know if you can see it. I'm sure you can see it. So complications, biggest complication is myocarditis, and then it can travel to the brain, and you can have some nervous system toxicity. Overall, mortality is about 3%, higher in those with delayed presentation of myocarditis. In children, it's higher in those that are less than 15 years old, and in adults who are greater than 40 years old. So again, it's on that spectrum of young and old. So as far as diseases wise, it sucks to be young, it sucks to be old, because you're the ones who get sick. You all are in the middle. So right now you're all safe. You guys get sick, you usually resolve pretty well. So how do you diagnose it? You can do a pharyngeal gram staining culture. So that patient that came in, you'd have taken a swabbed it, sent it for culture, and then obviously if they had that big open wound like a cutaneous diphtheria, you would take again a culture swab and send that out. It is important to start treatment right away if you suspect diphtheria, and not to wait for laboratory confirmation. So in that patient, I'm pretty sure, if I remember right, we went ahead and treated him with an antibiotic that would cover for diphtheria. So these are just differential diagnoses. So epiglottitis, angioedema, mono, acute pharyngitis, because that kid does look like someone who could have acute pharyngitis. And then sometimes some people have just swelling of their neck, sore throat, you would think mono. And I think we actually sent him and tested him for a mono spot and it was negative. But those are things that you look at that patient that you might think, you might could have that. So treatment, there's an antitoxin for this. It's called the diphtheria antitoxin. It's injected into a vein or muscle. It neutralizes the diphtheria toxin already circulating in the body. So it doesn't help recover what was already lost, but it can help prevent the disease from progressing. And so the only thing that you hope is that, oh, maybe I'm getting this confused. Oh, sorry, that's for botulism. So before giving an antitoxin, you can do some allergy testing. So if they're sensitive to it, you can do sensitization, so you give them a little bit at a time to grow their tolerance to the toxin. Antibiotics, so diphtheria is also true with antibiotics such as penicillin or erythromycin. They usually, which we didn't isolate this patient, but diphtheria patients are usually kept in isolation until they are no longer contagious. So it's about 48 hours after starting antibiotics. So if you have someone who is confirmed to have diphtheria, you want to isolate them because you don't want them walking around coughing, spreading it to everyone else. For cutaneous diphtheria, you clean the lesion really well with soap and water and give them systemic antibiotics for 10 days usually. And then you always want to vaccinate them if they've had diphtheria, because just because you have diphtheria doesn't mean that you're immune to it. So you should always give them the immunization after. So those who are, let's say you have someone that is actually diagnosed with it, you also want to check those who are in close contact with that person, because the likelihood of them contracting diphtheria could be high. So you would test them, watch for symptoms, recheck them at a week, but I think you also should treat them prophylactically with either amoxicillin or an erythromycin. So prevention. The best way to prevent diphtheria, again, is to get vaccinated. So in the U.S., there's 4 vaccinations used to prevent diphtheria. It's the DTaP, Tdap, DT, and TD. So each of these vaccines prevent diphtheria and tetanus. So DTaP and Tdap are also to help prevent pertussis, which is whooping cough. And there's actually been a resurgence of that. So in the last, I think, 5 years, they've recommended anybody who's pregnant to get that whooping cough vaccination, as well as any caregivers that will be taking care of their baby to be vaccinated for that as well. But again, that resurgence is due to lack of immunizations, so that's come back. DTaP and DT are given to children younger than 7 years old, while Tdap and TD are given to those older children, teens, and adults. So a lot of time, I remember, I think most everybody comes and gets the Tdap at 10 years. And Dr. Latassi will go over that with you guys in more in-depth. Don't be a sloth. Get vaccinated. Okay. And the last one I'm going to talk about today is botulism. Anybody know anybody got botulism or had botulism?
I think there was a doctor at Lakeside actually that had got botulism. They could no longer practice.
So what she got, what Lindsay's talking about, there was a physician who received Botox, botulism, botulinum, I think it's A. And I think this was at least 10 years ago maybe. So there was some clause that when she signed the paperwork to say, yes, I'll take the risk of getting a Botox injection, there was something in that paperwork that did not cover that practice, because there was something in it that didn't tell the patient what could go wrong. So she got botulism, and she had really bad side effects. She got the neurological symptoms. She was an OB, and she could no longer practice. And so she sued Botox, or the people who made Botox, and she actually won. I think it was like $1 million case or something like that. But there was something in that form that they used that they left out, that Botox, or whoever the maker of Botox left out, that she won because of that. So I'm sure they changed all of their paperwork, but that's what happened to her. She got a lot of the neurotoxic effects from Botox. Because if you read it, if anybody's, you guys are probably not old enough, anybody who's ever gone to get Botox or Dysport, if you read the side effects of what can happen from an injection, it's pretty bad. I mean, because you're never going to know if you're allergic to or not, or have a bad reaction until you get an injection. I'm dying. And the hour, I'm pretty sure I have silent reflux. It's one of those. So lecture objectives. So what is botulism? So it's a rare, life-threatening disorder that occurs when botulinum toxin spreads hematogenously and interferes with release of acetylcholine at peripheral nerve endings. So it's a medical emergency and sometimes a public health emergency. So botulism is produced by the toxin by bacterium of Clostridium botulinum. It's an anaerobic, gram-positive, rod-shaped bacteria. It creates spores that can remain dormant for 30 years or more. So some people have used, they think of bioterrorism, that people can use Botox as a bioterrorist attack. The spores are extremely resistant to environmental stressors such as heat and UV light, so it can last a long, long time. So there are 8 types of botulism. It's A through H, based on the antigenic properties of the toxin produced. It's so funny, last year when I did this lecture, there was only 7. Now there's 8, because it only went to G last year. Now it's up to H. Toxins A, B, E, and rarely F and H affect humans, so it's mainly A, B, and E. About 50% of foodborne outbreaks in the U.S. are caused by type A toxin, followed by B and E. Toxins C and D cause illness in birds and mammals. And then toxin H is the most potent toxin known. So categories of botulism, obviously the most common one you guys know is probably the foodborne botulism, caused by eating foods that contain the botulism toxin, or infant botulism, caused by ingesting spores of the bacteria which germinate and produce toxins in the intestines. And then there's wound botulism. It's C. botulinum spores that germinate in the infected tissue. And this is where they can use for bioterrorism, is an inhalation of the spores of botulism. Because it does not occur naturally and may be indicative of bioterrorism. So home canned foods. So remember, well, you guys haven't had peds yet, but you know what, if you guys have nieces or nephews or children, what are you not supposed to feed them? Honey. So home canned goods. So anybody home canned foods, or anybody know anybody does? So you were at risk this time, all these years of home canning food for botulinum. But it's particularly low acid foods such as asparagus, beets, and corn. In 2015, and improperly home canned potatoes were implicating the largest U.S. botulism outbreak in nearly 40 years. So I don't know if these people home canned their potatoes and then sold them and distributed them out, but it caused a big outbreak in 2015. So honey, so ingestion of honey, because they can contain the spores. So again, you don't recommend giving it to anybody less than 12 years of age. Or 12 months of age, I'm sorry, 12 months of age. It's so funny is when my child was little, obviously I knew not to give them honey, and they also say try not to give them like peanuts and strawberries before the age of 1, just to, again, they could develop allergies to it. I remember the honey, but I gave my kid peanut butter, I gave her strawberries, all when she's little, and I'm just thankful, I guess, that she never did get a reaction to it. But I know those are the big ones, is strawberries. People have a lot of allergies to strawberries. Anybody have allergies to strawberries?
But with peanut butter now, they tell you the earlier the better.
Well, it's so funny, because my friend, when she was pregnant, she was like, I'm not eating any peanut butter because they tell me not to eat peanut butter, because you could pass on a peanut allergy. But I ate peanut butter the whole time I was pregnant, and my kid doesn't have any allergies to peanuts. So I think it's funny that a lot of my friends who were very cautious when they were pregnant, their kids actually have more allergies and get sick more often than I did. I didn't care. I was like, Listeria, give me that Subway sandwich. Because that's a big thing. You're not supposed to have, uncooked meats. I ate sushi, but I think I ate like salmon, every once in a while. I try to eat the cooked sushi, but I just remember I'm like, yeah, peanut butter, give it to me. So obviously other sources is crush injuries or IV drug use. Again, open wounds. Those IV drug users, you should at least tell them instead of drugs are bad for you, you can get botulism, you can get all these other bad things. Just pictures of honey, canned foods. So, the incubation for botulism is unknown, but usually in foodborne it's 6 hours to 8 days. In a wound, 4 to 14 days, and inhalation is estimated at 24 to 36 hours. So you can see how if someone would use botulism spores as a bioterrorist attack, I mean, people would get sick pretty quick. The toxin enters the bloodstream from mucosal surfaces or a wound. They bind, like I said, to the cholinergic nerve endings, and again, inhibit the release of acetylcholine, preventing muscles from contracting. So they get symmetrical descending paralysis, beginning with the cranial nerves and progression downward. So I know it's descending. What's an ascending paralysis? Guillain-Barré. That's another thing when I was in PA school. I was pretty sure I had Guillain-Barré. And that's why I really didn't want to get the flu shot, you know? Because if you read the side effects of a flu vaccination is you can get Guillain-Barré. And actually a friend of mine, he was a paraplegic, but he got the flu shot and he actually developed Guillain-Barré syndrome, which I thought was interesting, but because I thought his nerve endings were already dead down there, but he actually got Guillain-Barré. Botulism can result from airway obstruction or paralysis of respiratory muscles. So secondary complications is prolonged ventilator support in ICU. Because, I don't know, it has nothing to do with this, but have you ever seen anybody who's had Guillain-Barré or know anybody who has?
Okay.
I went to see somebody in a hospital and it was horrible. I mean, it was like basically, they're all the way up to here. So once they get up to here is where it's the scary part. And same with botulism, you know, you cut that airway off. That's what's the scariest. Can you imagine just get an ascending and you just wait for it to get past your chest wall? Did your friend survive?
It was somebody in my high school, I think she was like a junior when I was a freshman, and I was told that she got it after getting the Gardasil vaccine, but she only, I think, got to, well, she was probably in the hospital, so it may have been worse, but by the time she was back to school, she was in a wheelchair for a while, and then moved back into crutches, and then was able to walk at the first senior year, but it took her a long time to get her legs back.
Yeah, and then anytime you have prolonged ventilator support, you always have the risk of getting pneumonias, all the kind of bad things that are associated with it and that can cause people to die. So, botulism cannot be transmitted person to person. Standard precautions should be taken when caring for any patient with botulinum toxin. Signs and symptoms. So more than 90% of the patients with botulism will have 3 to 5 of the following. They'll have diplopia, drooping eyelids, slurred speech. Their pupils can be fixed and dilated. They'll have dysphagia, and extremely dry mouth. So again, if you know anybody who's ever had head and neck cancer, they get this xerostomia that as much water as they can ever drink, it never feels moist. So they can begin to progress to paralysis and respiratory weakness. Infants with botulism will present with a weak cry, poor feeding, constipation, poor muscle tone, and the floppy baby syndrome. So I was trying to get a good picture. This is like the best I could find. He kind of has in the first picture kind of like that droopy eye. His eyes are kind of droopy. He smiles okay on the right side. So his pupils are big and they're fixed, but he could also have that normally. I couldn't find a really good picture of someone with a botulism. So how do you diagnose it? You can do a toxin assay. You can also sometimes want to do an EMG on these patients to differentiate from other types of neuromuscular disorders. So you can, the botulinum toxin can be identified in the following: from blood, from stool, from vomit, or gastric aspirate. Obviously, if anybody brings in any canned foods, you can check the foods as well. And then you can grow it on selected media from stool or food samples. So the treatment of botulism, they have a equine heptavalent antitoxin, and it covers the botulism A to G. Again, this is the one, it does not inactivate the toxin that's already bound to the neuromuscular junction. What it does is it will slow or halter further degeneration. And then what you hope for is that eventually their nerves will regenerate and they will get their function back. But they may not or may never, it may take weeks or months, which is amazing to me that your body can do that and you can restore it. And you've heard stories about people who are originally quadriplegics, but then with time their body regenerates their nerve endings and they become a paraplegic. Or is anybody watching Dancing with the Stars? Anyone? They're like, what's TV? I don't even know what TV is. Well, there's a girl on there. She's a ESPN newscast host, and when she was, I want to say like 14, she got some weird illness, and then she got really sick, and she slipped into a coma. She was in a coma for 4 years. Her family did not give up on her, and she said she could hear them the whole time she was down. She could hear everything that they would say. But she eventually, one day, she just woke up. And slowly with time, she started, getting her function back. She was in a wheelchair, moved to crutches. And now it's amazing, she's on Dancing with the Stars, and she can really dance. But what's interesting is that she can't feel her feet. Like, she doesn't know where her legs are in real time. Like, she knows that she's moving them, but she doesn't know if they're actually really moving, which is interesting. But that's basically numb all the time. But I was watching her story and I thought, 4 years. You see all those people like hang on to their family. And then, that's actually the second story I heard about. I heard another story about a man that was in a coma. I don't remember how many years. It was a long time for him. But he eventually woke up. He didn't recover as well as her. I think he has to talk through a laptop, but it's amazing to see that people can recover like that and to come out. By the time 4 years, think about it's passed, the cell phone came into play before, it wasn't there when she was little, so she picked up her first flip phone. And then think of all like the Facebook and all that came aboard that while she was asleep. That was interesting. But so, this is how I think you place a patient who has botulism. You want to put them with their rolled cloth for cervical support. You want to elevate their bed and bumpers to prevent them from sliding downward off of the bed. So hypersensitivity to the antitoxin, 9% of people experience some hypersensitivity. And again, with those people, you can do the desensitization where you give them a little bit at a time to eventually where it sensitizes them to that toxin, or antitoxin. So here's a list of differential diagnoses. So when you have a picture that kind of shows up like that, you think about Guillain-Barré, myasthenia gravis, stroke, paralysis, Lambert-Eaton syndrome is. Sometimes it could be malingering, so you think of a psychiatric illness, poliomyelitis, diabetic complications, a drug intoxication, some other form of CNS infection, or just due to overexertion. I'm sure you guys talked about this in psych. I mean, the mind is a very powerful thing. People have a lot of psychiatric illnesses that are induced. They really think they have these symptoms, but they don't. So it's a lot of malingering. So again, it's up to you guys to do a good physical exam and history when differentiating this from an actual disease. How do you prevent it? So there's no vaccine that's currently licensed for public use. They do have a vaccine for people who are in close contact, who work in a lab with botulism, or any military personnel that again is at high risk. It requires multiple injections, and they usually don't use it in the civilian population. But limited supplies of the vaccine is available, and again, you would call the CDC, or you would talk to someone who is working in that environment that may require the vaccination. So how to prevent it is really correct canning and adequate heating with home canned foods before serving are basically essential. I don't know much about canning foods. Do you put it in something like in a lid?
Usually, like my mom has this huge pot that has a lid and it's kind of like a pressure type.
Is it a pressure cooker?
Yeah.
Some put it in my dishwasher.
Dishwasher.
The,
The cans with the food inside them.
Like the jars, you put them
into the dishwasher to heat
Like
it?
you
Yeah.
put the lids on, you put them in the dishwasher and the heat seals them.
Yeah.
So, but my mom didn't have a dishwasher, so.
So how would
She
you
used
use
a
it?
huge pressure cooker, it's just a big pot and she just put it in there.
Pressure cooker's the other one that's
Yeah.
lacking gas, because that's all.
And so when you home can your own foods, how long does it last?
Oh my gosh, years.
Yeah, just like you would a regular canned food item?
Forever.
And you home can just because it tastes more fresh?
My dad just makes pickles, like she'll make pickles, she'll grow cucumbers and then make her own pickles.
We did
Or
the
like
same thing.
pickle okra or things like that.
Surplus from the garden.
Yeah.
Does it taste better?
Oh my gosh, my mom's pickles are so good.
Really?
Yes. You can do so many jams, so good.
They broke down.
I don't think dark green
Yeah.
beans is really good. Even after.
Green beans? I've never had, like, other than the kind you buy store-bought, I've never had home canned foods.
You just have to check for the seal, like, that's why they say not to buy, like, dented
Oh, because you can have seepage out of, like, a small little nick in the cans.
Or like the you know.
The pressure's out.
Like heat it, so, you know,
Yeah.
that's what's good.
Well, let's see when they go back out, then canned food. It's just kind of like deli and
So there's other therapeutic uses for the botulism toxin. You can use them for focal dystonia, so people have cervical dystonia, torticollis. You can inject botulism or Botox into the neck, into the C-spine, to help with muscle rigidity. That's a spasticity. You can also use it for, obviously, for facial wrinkles and things like that. Strabismus and nystagmus, there's been use of the Botox in that as well. Disorders of local muscle spasms and pain. It's cosmetic use, obviously, and sweating disorders. So like we talked about earlier, you could, you know, I think Professor Hughes talked about it, you can have Botox injected into your armpits and into the hands for, you know, hyperhidrosis. Well, I think my brother-in-law actually suffers from hyperhidrosis. He always wears 2 t-shirts all the time, and he's still super sweaty. My niece, I think she kind of suffers from it too. She doesn't wear 2 t-shirts, but she's always kind of sweaty. So they just kind of have hyperhidrosis in the family. But the people, I mean, when he did actually have the Botox injection into his armpit, he said it worked really well. But again, it's just like any Botox in the face, you know, it's the upkeep. You have to go back every, 3 to 4 months, and to get it injected. I think with time, the longer you use the Botox, and even for the face, it will, the more you use it, the longer it'll last. Maybe the first few times it won't last as long, but as the further along you use it, you atrophy the muscle, in this instance, the muscle and the gland, then eventually it could go a little bit further along. You can not have to do it as often. So, questions? Yes.
Do they also use it now for migraine headaches?
Yes, so yeah, they have used that a lot for migraines. We use Botox in the ENT clinic for vocal disorders. People have vocal dystonia or dysphonia. We use that. We would actually inject it through the neck into their laryngeal muscle. Because the people, I don't know if you've ever seen older people or even younger, that they're like the ground and crackle like this, but they talk like that. So you would inject the Botox into their muscles to help relax that, so they don't have as much of that spasming when they speak. Hi. Dr. Liz Cassie's next. You guys have missed her. She hasn't been here in a while.